Hi, I'm Dr. Sam Alfasi, a gastroenterologist in Toronto, co-founder at Keops, and the host today on Under the White Coat. This is a weekly series where we sit down with key opinion leaders and get to know the personal side of the physicians sort of leading today's healthcare and try to learn something new about their specialty. Today, I am super honored to have Dr. Ilana Halperin, who's an endocrinologist at Sunnybrook Hospital, and she has a very impressive resume and some very interesting things that we're going to talk about today, where she is the lead in innovation at the University of Toronto in the Division of Endocrinology. And something that also scares me quite a bit is she's the medical director of the diabetes and pregnancy. I'm very scared of pregnant people. My wife has gone through it 3 times, and but it always wows me. So welcome, Ilana.
Thank you, Sam, so much for having me today.
Awesome. So I just wanted to start off, part of Under the White Coat is where you really just try to get to know some of the key opinion leaders and get to know them also on the personal side. I think we'll talk a bit medicine and some interesting things that you're up to and your opinions, but why don't you start off, just tell us a little bit about yourself.
Yeah, of course. So I was actually born in Calgary, but raised in Toronto, and I did my undergraduate at McGill and medical school in London, where I got to meet Sam, who is a roommate of my now husband, and then my internal medicine endocrinology training in Toronto. I was in the inaugural class of the Quality Improvement and Patient Safety Masters at U of T, and that's definitely what kind of sparked my whole pathway down innovation. And I was one of the first recruits in the Department of Medicine at Sunnybrook under a job description that's called CQI. And people often think the I stands for improvement, but it actually stands for innovation. So it's a clinician whose focus is quality and innovation, rather as the more traditional sort of clinician teacher or clinician scientist. This is a new job track. And so I was one of the first people hired back in 2013. And I've been working at Sunnybrook ever since, doing general internal medicine and endocrinology.
That's awesome.
Did you want to know about my kids?
Oh, great. Yeah, I would love to know more about your kids.
So like in my spare time, I try to look after 2 very rambunctious boys, ages 5 and 8, who are totally obsessed with sports. And the return of professional sports during COVID has been my lifesaver. When I make the calendar for the week, as in what activities they're going to do, since there's no structure to this COVID summer, it's when's the Raptor game, when's the Jay game, when was the Leaf game. Now they're happy to watch the Habs and the Islanders. So we just put the schedule with all the sports, and that's the screen time that I think is okay, because it's actually really good at teaching them hard math. And my 5-year-old is amazing at when the Raptors win like 117-94, he can tell me how much they won by. So that's my COVID summer win.
I love that. You know me and small world, how we know each other, and I'm an avid sports fan, big Raptor fan. So yeah,
I know.
And that's great. So yeah, thanks for all of that. It's great having at least the viewers get to know you a bit more. I love the innovation side. I'm sure you know I'm very actively involved in health tech and innovation. Work with a lot of startup companies, help them sort of progress along. But I would love to know, how did you get involved in innovation?
So I would say that it was actually the quality improvement piece that made me interested initially. And I sort of always knew I wanted to be an academic physician, but I wasn't particularly turned on by the real research track. And I was a decent but not exceptional teacher. And then this whole field of quality improvement with sort of, the Institute for Healthcare Improvement, Model for Improvement and stuff, they just started talking about it when we were residents. I'm sure you remember, Sam. There was like no mention of the word quality improvement when we were medical students. And now it's a huge part of the medical school curriculum, for which I've been involved with designing. But just the idea that when you do care, it's not just one patient at a time, but thinking about how you can improve the healthcare system, whether it's as small as your own practice or as large as the healthcare system. But part of improving is innovating and looking at what we're doing today and thinking about how we can do it better. And so I think for me, that's just been applying that sort of quality improvement methodology to healthcare innovation has been something I've been excited about since I started my training in that area as part of my master's. And it started really, I think, with knowing that when I was going to have a busy outpatient practice, I did not want to do it on paper. And I sort of brought the rest of the endocrinology division at Sunnybrook out of the dark ages by implementing an EMR, and not just implementing an EMR that's basically a paper chart, because a lot of people do still use their EMRs as an electronic version of their paper chart, but in sort of implementing an EMR that would allow you to do quality improvement. So not just dictating a note, which is all free text and not searchable, but actually creating forms that allow you to capture data at the point of care, of clinical care, that you can then use to kind of understand your patient population, identify areas for improvement. And that was a big part of my early work as an academic, was doing this project called the Diabetes Scorecard, where we tried to get data from all of the different endocrinologists across the across U of T, which is 5 hospitals with 5 different data management systems. So it's a huge headache, and it's still a work in progress. But that was sort of my early piece of innovation. And then I think we're going to speak to virtual care, which I think is my next step from the EMR world. And I guess I could just say one other thing about the EMR world was that I joined an organization called Ontario MD, which I think a lot of our physician colleagues don't know enough about. So I would like to highlight it, because it was actually the organization that doled out funding for physicians to move to EMRs. And obviously that pool of funding sort of finished up around 2014, 2015. But it's still an organization that's built to support physicians in their digital healthcare innovation. And there's a lot of free resources available through Ontario MD with your OMA membership. And you can have people come and visit your practice and see how you're using your EMR and other digital tools, because there's so many add-ons to the EMR these days, which are so great in terms of secure messaging and automated patient reminders and all that stuff. And they can help you optimize your workflow. And so I work as a physician peer leader for that group. I will be giving a talk at their Digital Health Day, which is coming up on, I think, on October the 2nd, with Noah, my husband, about doing virtual diabetes care in 2020. The specialist and the primary care physician perspective.
That's incredible. I think definitely I think you preempted, and we'll definitely talk about virtual care. I think we'll talk about that next, but it definitely reminds me of when I started my practice, the physician who was retiring, I was telling him about, we're going to go all EMR, because they were all paper-based at the time. And he told me, because they were just working just straight out of a day planner, and the entire schedule
with a pencil,
exactly, and the whole day planner for the whole year, all the procedures, everything. And I'll never forget, he told me, well, what would happen if you lose your computer? And I said, well, what would happen if you lost your day planner? So I think definitely making change and going digital is a huge, massive step. And I think, and that it brings us to the next conversation piece is is virtual care. And I think, my opinion is COVID has really pushed us forward, probably a decade faster. And it's shocking. I think we're in what my term is now, we're in the year 2000 in medicine.
Yeah.
And that's COVID has brought us to that point. Why don't you tell us a bit about your experience with virtual care? And I think you're an expert in that field, and sort of what we're up to, and where do you think COVID is leading us now with virtual care?
Definitely. I think the virtual care story is just fascinating, and it's certainly the silver lining, if there could be one, from the pandemic that we found us in. So for about 3 years prior to the pandemic, Ontario Telemedicine had a pilot project called the Home Video Visits Project, and they were enrolling specialists, and it was not necessarily academic specialists, to deliver video visits to patients who are at home. So for those of you who don't know, OTN has existed for, it may be 20 years, like since the actual year 2000, to provide sort of tertiary specialty care to people in rural and remote communities, but they would have to go to an OTN center at their local hospital where a nurse would be with them, and the physician also had to go to a special room in their hospital, and so it wasn't a very readily used service. And then in around the year 2017 or 18, they sort of realized we probably have the technology that we could do this with patients who are in their own homes, and physicians could be basically anywhere as well. So I enrolled in that project because endocrinology really lends itself to virtual care. We're very much a laboratory-based specialty, and I may offend some of my more senior colleagues who tried to teach me the physical exam, but the reality is there is very little that the physical exam adds to my assessment when it comes to looking after patients with diabetes, thyroid disease, polycystic ovary syndrome. It's real thyroid cancer. It's really all about the imaging and the laboratory tests and having a conversation with your patient about how they're responding to their medications. And so when I last summer, this was almost a year ago, I think it was over a year ago now, because it was sort of the first week of August leading up to the August long weekend, I did a virtual clinic from my cottage. It was about 12 patients. I had to set up 2 laptops so I could remote into my EMR and be on the OTN platform. And my secretary was in the office in Sunnybrook, and so I would be texting her if a patient wasn't online. And so it was not super easy. But when it was done, I walked over to the lake, and I was with my kids within 10, not even 10 minutes, and I tweeted about it, and it got international attention. And that's really how I became the virtual care expert, because of Twitter. I took a picture of my computer with the lake in the background and the OTN logo and said, I just did my first virtual clinic from the cottage. We've finally arrived in the 21st century. And I got international response. It was really the coolest thing. And then I got asked to give the inaugural Health Quality Ontario rounds under Ontario Health. It was around February of this year. So about 6 weeks before the pandemic hit. And I talked about what's virtual care now and where do we need to go with virtual care. And one of the things I talked about was that phone calls is a very acceptable way to provide virtual care, and we don't do it because we don't get paid for it. And I remember some of my colleagues who are a little bit less comfortable talking about what drives physician behavior when it comes to money. Some non-physicians were like, I think you talked about money too much. And I said, no, actually, we need to talk about money. We need to talk about how we pay doctors. We pay doctors appropriately sometimes, and there's other times where we don't pay them appropriately at all. And that's why physicians don't talk on the phone with their patients and make them schlep in just to review the results of a couple blood tests. Some doctors are very great and they will call here or there, but if they called everybody all the time, they would be working for free. And I talked about a couple other key enablers to virtual care, but there's nothing like a pandemic to enable virtual care. And so like 6 weeks later, those K083 codes came out, which changed our lives. And now I would say I'm doing much less video virtual care and much more phone calls because it works. And the other thing is with the pandemic, the OTN platform just like imploded. There are just too many people were trying to get on it. The connectivity really failed. And so in the last 6 weeks, I've actually switched over to Zoom Healthcare. And the reason I didn't switch over to Zoom Healthcare right away was there was a lot of controversy. For those of you who are still eligible for the chronic disease premiums, the E078 codes, you'll recognize why we were hesitant, because there was a lot of back and forth with the Ministry of Health as to whether or not we'd be able to roll those into our K083 codes. And so I was kind of just doing diabetes on OTN as much as I could, so I could be sure that I could be paid what I deserve to be paid for diabetes care, and then everything else on the phone. Now my approach is Zoom for new patients, because I think when you're meeting a patient for the first time, they and you appreciate seeing what the person on the other end looks like. But then once I know the patient, the follow-up on the phone is just a little bit easier. I feel less bad just calling the patient as opposed to knowing they logged on to Zoom, and like you did for me today, Sam, they're waiting and wondering when's the doctor going to log in and all that stuff, because just like a real clinic, a virtual clinic runs late. So I probably yacked too much there, but that's sort of my journey with virtual care. And I do think and believe that the public is going to demand of the Ministry of Health that this not go away, because it's so clear that physicians will make the call and they'll bring you in when they need to bring you in. And so much care can be properly delivered virtually, over the phone, asynchronously. That's the next thing we need to get billing codes for, is a sort of email communication with our patients.
I think you hit on a lot of huge points there. Yeah, I'm calling, we're having this call right now. I'm just actually in my office. I just finished the full day of a virtual clinic. And I actually echo a lot of what you said. I was blown away with how much I can get done really just over the phone. and calling my patients. And I think my patients love it that we just speak over the phone. And, I have patients that I caught them while they're doing laundry or they're at work and they just step away from their desk and they don't actually have to take an entire
once or
day off.
twice I've called a patient and they were at the grocery store and I found that a little annoying.
Right,
hold on, doctor, I just have to pay. Hold on, doctor, I just have to grab that off the shelf. I was like, we had an appointment.
Right.
But in general, most people are also working from home right now in the pandemic and all of that stuff. And so they're just like, I've had patients where I've been on the phone with them and then the resident texts me because I've been running education clinics virtually too. And the resident will be at the hospital and I'll be at my home office. And the resident will text me and be like, ready to review. You can join our Zoom call, which is fantastic. I love reviewing on Zoom. Like Zoom is so much better than OTN for me, the patient, and the resident all together. And I'll say to the patient on the phone, you know what? The resident's ready and I don't want to leave that people. Can I call? Sure, of course. Call me back. I'm not going anywhere. Right. And you could never do that if somebody was actually in your clinic. You can never be like, sorry, I got to leave you here so I can go review with another patient. So then you leave the patient with the resident waiting and someone's always waiting. It's so much better.
Right. And I also find that while you're running late, I think it's inevitable. Like some people just require more time. So while you're running late, people are less offended that, they're just going about their day and then you call them a little later and that's fine. They weren't sitting in a waiting room, just waiting around for you. Yeah. I think, to be honest, for everybody, it's a good thing. I'm hoping that this can stick around for just quality of care and access to care. I think I actually see a lot more patients this way than trying to physically bring everybody in. So,
I completely agree.
Now, so I think, just like you said, I think COVID, accelerated sort of the acceptance of virtual care. How do you find maybe it is COVID, or what have you found has accelerated some innovation lately, in particular, maybe in diabetes?
Mm-hmm. So I think the thing that I'm most excited about in diabetes right now, and we could talk about, there's so much to talk about in diabetes. Like we have a plethora of drugs that help people lower their blood sugars and also reduce their risk of cardiovascular and renal disease, which is extremely exciting for the diabetologists who used to give drugs that cause people and they help them lose weight too. And so that's really exciting. But my real area of interest and focus is continuous glucose monitoring. And now that's primarily for patients with type 1 diabetes, but there's a growing understanding that the Libre device, which is what we would technically call a flash glucose monitor, and you've probably seen ads for it on TV or at the bus stops or just people walking around outside with this little white toonie size thing on the back of their arm. That's the Libre. And I actually think that there's a growing room space for that in patients with newly diagnosed prediabetes or type 2 diabetes because it's such a helpful self-management tool in terms of understanding the impact of food and activity on your blood sugars. And COVID has accelerated the desire for people to use these devices and the desire for endocrinologists and diabetes educators to have their patients using the devices because it's such a fantastic way to share data. So it's basically remote monitoring, but it's not just like a patient being at home wearing a Holter for 2 weeks where the patient doesn't really know and then retrospectively, the cardiologist reviews the Holter. We used to have professional CGMs. Like we never had them in Canada. They use them in the States. But the patient is seeing their data in real time. But one of my areas of expertise, and I just found out today, I got a paper accepted about this whole topic, is how to use that data as a healthcare professional to help your patients make informed choices about their diabetes management. And so there's a whole area of literature around taking these minute-by-minute glucose values, which are totally overwhelming and hard to interpret, and putting them into what we call an ambulatory glucose profile over a 2-week time period. And it's completely changed the way I do diabetes care. And now when I have a patient who's not using one of those devices, I'm like, I don't really know how to help you. Which isn't great because they're not universally accessible devices right now. And that's actually another area of interest in work for me is advocacy around making these devices provincially covered because they are life-changing for the people with diabetes and honestly for the endocrinologists that look after them because it's just now when I look at that, I ask the patients 2 or 3 questions and it's so clear. I know exactly what I need to tell them. Sometimes I tell them I know what behaviors they're doing without them telling me. And they're like, how did you know that? And I was like, once I look at the profile, I'm like, you're a little nocturnal. You eat till about 2 in the morning and you don't eat again until 2 in the afternoon. How did you know that? So it's really cool because it was totally different I'm sure you have this in GI too, but we didn't learn any of this in our training. This is all learned by doing and innovating with my patients in the last few years. And so it was definitely happening pre-COVID, but I think COVID has accelerated it and accelerated the need for really easy ways to share the data. So the two leading companies have apps on smartphones, and then you can put in a special share code for an individual clinic, and then I can see their data instantaneously. So it really facilitates good virtual care. And actually, in the diabetes and pregnancy space, it definitely facilitates good virtual care, where we've been almost entirely virtual in that space. They only come to the hospital to see their OBs. They don't come to see me. They don't need to, because all I need to know is what's happening with their numbers.
That's amazing. That's an amazing use of technology. Do you find that your colleagues are utilizing this as much as you? Maybe not as much as you, but utilizing it?
I think more and more. Like, I hope that I would be considered sort of on the leading edge of endocrinologists in this space. I'm getting called upon to give a lot of talks about it. At the beginning of COVID, I gave 3 different Diabetes Canada virtual care and COVID. Sorry, it was diabetes and COVID webinars. They had about a 6 or 7 part series. They asked me to do one just on how do we quickly pivot to virtual care. And then I did 2 with a fantastic diabetes nurse educator on all the different technology and how to use it in your practice in a virtual environment. I didn't even talk about insulin pumps, which is a whole other exciting area of innovation for people living with type 1 diabetes, because now the sensor can inform the basal insulin delivery on the pump, and we're kind of what we call closing the loop and sort of almost reaching the holy grail of an artificial pancreas. So it's really like a very, very cool and exciting time to be working in diabetes. But I do think that there's a few barriers to use for some of our physicians. The same ones who probably aren't using an EMR are not really super savvy at quickly flipping. Like I love being at work because I need my 2 screens because I got my EMR. And then I've got the Libre View, which is for the Freestyle Libre, or the Dexcom Clarity for the Dexcom, or the CareLink for the Medtronic pump. And you've got all these different websites. And so there could definitely be improvement for us on the physician side if everything was in one place to see everyone's data. But it doesn't really bother me that much. I can flip between it. But I think for other people, it's a bit overwhelming. They're used to the diabetes educator like printing out the report and like handing it to them.
Right. Which
doesn't work in this virtual world.
I think you're giving out some gold to some of our health tech innovators who are listening in. Putting something together, a platform to pull in all this data would be, ideal for management. Ilana, you were terrific, and I think we learned a lot during this. One way we end all of our Under the White Coat, we chat about something just a little fun and interesting about you. I heard you just got a new dog.
We got a pandemic puppy. But she's not a puppy. She's like 60 pounds.
Wow.
Yeah. So we always wanted a dog, but I was always finding a reason to put it off. And then with the pandemic and Noah really very much working from home, we sort of said, this is the time. There's never going to be a better time to have a dog at home. So it wasn't so easy to find like a fresh puppy. So we found an 8-month-old St. Bernard poodle. Her name is Penny Lane, and she's part of the family now. And she's really, really sweet, and the boys absolutely love her. So it's fun. There's moments where I think, why did I sign up for a 3rd kid? Like when I'm picking up her poop from the backyard, or having Noah say, no, you can't go work out right now because someone needs to keep their eye on the dog. And I'm like, but I didn't know. Can't we just put her in the crate? But overall, she's definitely been a positive addition to the family. I think a lot of people got pandemic puppies.
Yeah, that's awesome. And also probably a good workout partner going for a run. And
definitely. Yeah. It took her, when we first got her, because she came from the country, she was so scared of even just like walking beyond our street's pretty busy, and walking beyond our property line. But she's definitely over the last 3-4 months warmed up, and now I can go on a great fast-paced walk with her, and we could probably start running.
Nice. So yeah, definitely a new part of the family, and hopefully also a Raptor fan.
Yeah.
Not Habs fan. I have none of that. None of that.
So that's my dad's Montreal roots rubbing off on my kids.
Yeah. Awesome. Well, thanks again, Ilana.
Thank you very much for having me, Sam.
I had a lot of fun, and hopefully we'll speak again very soon, and we'll hear a lot more about some of the innovation you're helping lead and being on the cutting edge of endocrinology and innovation.
Thanks so much. It was a pleasure.